So the first case is a 31-year-old male who weighs 162 pounds and we get called out for an injury. But the chances are you'll recognize at least talks of this one.
Oh, but they got an Homestead.
So that's like, you know that,
Yeah,
then yes. You can tell me the exact address, I will confirm it. But yes, this was on Homestead. Let's say, so was this y'all's case? Okay, cool. So, this guy injured himself. He had lacerations to his neck and abdomen. This happened about 10 minutes prior to y'all's arrival, and this actually happened to be an in-service day. Do you remember that?
Yeah.
Okay. This is what we got on the patient as far as vitals and history. Couldn't get much. Anything jump out at y'all? Okay, he went from alert to unresponsive. This may or may not have been our doing, but
Entitle rising.
yeah. Although I suspected that first one was an error.
Satisfying.
Okay. Okay, we'll give you guys a second because this is a lot to digest. This is what we did.
Yeah.
So I said, don't get scared. So what happened? I think I heard RSI. Yeah, okay. So don't forget the bleeding control. It's really important that that happens first.
Like threat, bleeding?
Yeah. What do you guys think about the RSI doses?
Yep.
And then what happened?
Couldn't get the tube, so they
Okay.
used an eye-gel.
Couldn't get the tube, so what?
They used an eye-gel.
Yeah. Good idea, bad idea.
I mean, if he already had lacerations to his throat, you can't guarantee that it didn't cut his airway. You could have just gone for a crike at that point.
Ooh. Aggressive?
You already got his throat halfway there.
Aggressive?
Start
I'm not saying no,
Saying
but
that
one of
idea.
two
Good
things is
idea.
true. He either did cut through his airway or he didn't. So, let me try to give you guys a little bit more information, because what are some ways that you may assess whether somebody's airway has been cut all the way through or not? Bubbling, okay. So I'd say, I don't actually think that this is commented on in the exam, but for the guys who were there, was there bubbling?
No.
Thanks. So yeah, maybe cutting through the guy's airways, maybe not your best bet. And admittedly, if the guy does have bubbling coming through his airway, chances are you don't actually have to cut, you just gotta put a tube through the bubbles.
That's what I was saying, if it was already there.
You can actually use a regular old ET tube at that point. Just pick a little one. To be fair, I actually had a suicide attempt with a patient who was brought in this way. The guy had cut his own neck. He was like coughing, sputtering the whole entire time that EMS brought him in. And like right before they rolled in the door, the guy coughed once, ripped through what was left of his throat. And then now he's just like he's just aerosolizing blood out of his throat. He rolled into trauma bay that way, and the trauma surgeon just held him down and shoved in an ET tube. It's not pretty, but it works. So I think the iGel was a good idea in this case. Because when we have committed to like getting this guy's airway, we couldn't get the ET tube in, and so this is a solid backup. So I like it. And then the real question is, did it work?
That's it.
Did. As long as you can get it to seat and you can get the guy ventilated, sounds good. So, and we can confirm that with, did it work? Yeah, sure did.
On paper it did, yeah.
What does
We let him out of the hospital and he tried to kill himself
I
again.
know, I know.
I think in
So,
reality
it
it
worked.
did too.
I'm just saying, I wasn't there, on paper, I'm reading the paper, it says that it did.
I do think it's hard to fake stats of 98, so yeah. Okay, so this is our first assessment. Thoughts?
Guy's crazy. That's my thoughts.
He does seem to be quite disturbed in this moment because he really committed to this act. Do you feel like anyone who commits to slicing through their neck is
Plus all the
committed to the act?
multiple puncture wounds.
Mhm.
That's, pretty fucking crazy.
Yeah, he committed to it, and from what I understand, this happened like literally in like the middle of the road. Okay, yeah.
Yeah, just like to see the video.
No, thank you. I take it that means that y'all have seen the video.
Oh, yeah.
Okay.
Somebody's
perfect.
sitting in the car right in front of him videotaping.
Then we all know what these wounds look like, and that's a win. I think this is our repeat assessment.
Wait, this is the what?
This is the repeat assessment.
Oh.
It does include some pretty substantial changes that we did, and for good reason. It now says that he's pharmacologically paralyzed and sedated, so he's unresponsive, and we did that, and that's a good thing in this case. So I think it's probably not your primary management for excited delirium, which does work incredibly well. We'll get them to study. And this is our narrative.
Solid narrative, though. Good job.
Jeez, 10 to 15, good lord.
Yeah.
And I think it might have actually underestimated.
Yeah, I think there was more, and there's also apparently one in the chest I didn't see. I think he, at the ER, we got started developing it anymore. But, that was later on, but there.
I'll touch on that. I'll admit, I don't have this section here because he goes off to Leaf Flight, and so I don't have their documentation. But I can pick back up when he arrives at the trauma bay. So this is what I got as, this is the ED course.
21.
Oh, and you know what?
I was about to say, and even this is not, I was about to say, this is from the ER doc. There will be the next note is from the surgeon, and they also don't have the same numbers, but I want to touch on a thing that the ER experienced that we did not.
Hypotension.
Yeah. I take it this patient was a bloody mess. I also know this happens to be pre when we had TXA.
No, we still don't.
Okay. But I will also mention that the trauma bay did give this guy TXA for the bleeding. In addition, the trauma bay will trigger that anytime they're doing massive transfusion protocol. I don't think this guy met massive transfusion protocol for them because they only gave him 2 units of packed red cells. Massive transfusion is 10, 10, and 5. And so that'll be 10 units of red cells, 10 units of fresh frozen plasma, and 5 units of platelets. It's a lot of blood products, but it essentially mimics like 10 units of whole blood. It's a lot of blood. This guy didn't meet that criteria, but because he went hypotensive and needed blood transfusions, they went ahead and gave this guy TXA. Okay, so now when that little end there, when they're talking about like what happened. So as far as his neck wound, there is a muscle on the anterior surface of your neck called the platysma. I was about to say, did anyone remember about this from paramedic school and what the heck it does? So it has like this tiniest little function. It's this sheet of thin muscle that wraps all around your neck, and it's what allows you to do that, where you can tense up your whole neck. It is the top layer of everything. So if you're through that level of muscle, then kind of all bets are off as far as blood vessels, as far as anything, like anything underlying it. If you have violated the platysma, then I can't vouch for any of the blood vessels and anything underneath it. So that's why they had to do this, the exploration of the neck wound is because he did get through the platysma. Quite frankly, a lot of times when people try to commit suicide by cutting their own neck or cutting their own throat, they don't get through this muscle layer. It takes quite some effort to get through. And so most of them don't have to go for exploration, but this guy did because of that reason. And then, of course, so you stab into the abdomen, there's a good chance that you're gonna get into bowel. And so anytime somebody gets into the abdominal cavity, you have to do an abdominal exploration as well. So he's getting opened here, he's getting opened here. This is the note from the surgeon. Sorry, it's long, but they actually talk about like what happened in the OR and et cetera, et cetera. And please stop me if you guys have questions about anything that's written. I also noticed that this was a higher number than anyone had said before. So what?
There are no step ups.
It's excellent.
What's a ZOS in?
Which one?
IV ZOS after the TXA.
Ivizocin is an antibiotic. So it's if you cut yourself with that many times with a box cutter that you don't know where it came from, you
And tetanus.
can't survive the suicide attack and die of tetanus. So the other part that they commented on is so on the fast ultrasound, they'll look at different parts of the body to see if there are pockets of blood. One of the areas that we look is around the heart. They admittedly didn't see any blood around the heart. But then after the patient went hypotensive, they were like, look, we're opening him up here, we're opening him up here. We'll just go ahead and open up his chest too and do a pericardial window. So if you guys remember the pericardium, it's this kind of like hard fiber sac that lives around the heart, protects it from everything else. And so if you get bleeding within that pericardial sac, it doesn't have anywhere to expand outward because that sac is fibrous. So it starts crushing the heart inward. So they went ahead and cut a little window in that, and it literally is what it sounds like. You just cut a little square window in it. So that most of the heart is still protected by that sac, but the rest, like there's this little kind of like relief valve to where any blood that is in there can escape. So they went ahead and did that.
Did they find any blood?
That part is not clear.
Will that heal itself?
It will not. They will always have like a little bitty hole, but it's small enough that it lets blood out without like compromising the function of the pericardium. good news is he had not cut into his intestines. And I also am not entirely sure of the order of like kind of operations here because they comment on him getting the chest tube. But it also kind of seems like the chest tube was done after the fact, and I'll show you why. So, this is his x-ray. So this is a very busy x-ray, so like, let's break it down a little bit. So what we're really looking for is, let's do the ABC method to look at x-rays. So A is for airway, just like in anything else. So I'm gonna look at his, okay, so I'm gonna look at his airway. So it's gonna come down the center here, and then it's gonna branch here and here. Can you guys see that slightly darker gray point where it branches? Like, no. Better? And just to point out where we're talking about, we're talking about this slightly grayer path that comes here, and the slightly grayer path that goes here. So I'd say it's subtle. So that's the branch point of the carina, and what we're looking at is he has an ET tube that now, you see this like white line that comes down. It ends here where this marker starts. And that's right where I want it. So I want an ET tube to end below the clavicles and above the carina. So meets that qualification, is not in the right main stem, is above the carina and below the clavicle. So I got an airway on this patient. And his airway is centered, midline too, so that's good. So B for breathing. So now I'm gonna look at his lungs, and honestly, they look pretty fine. Yes, sir?
The thing up just above where it says 24 millimeters.
This thing?
Yeah.
Yeah. What is it?
Yeah.
It's actually part of the vent. I was about to say, honestly, they got a little lazy taking it because you're supposed to move those things up out of the way because it theoretically, like, you can obscure something behind it. Yeah. It's part of the vent. So his lungs, they look pretty good. I'm not seeing any like big rip-roaring pneumonias. I actually don't, in this picture, don't see any hemothoraces and pneumothoraces, but that's good because I have this chest tube going in here, up towards the apex of the lung where I want it to, because this was theoretically a pneumothorax, so I'm getting air out. And then circulation, I'm looking at the patient's heart, which doesn't look enlarged. This was theoretically post-pericardial window, so I wouldn't expect it to be anyway. And okay. So this guy had a very eventful first day. Obviously, this guy had a Baker Act that was put in place. He went to the OR for that neck exploration, the pericardial window, and the abdominal exploration. When he came out of surgery, he has a drain still in his neck because just any big wounds like that would continue to like drain and produce fluid. So it's almost this little bulb that gets squished, inserted in there, and then it keeps pulling suction on the wound so that it keeps draining whatever is in there out. You got that chest tube to the right side of his chest. And actually, after he came out of the OR, his numbers looked good. He was like moving, he was following commands. So they were able to get the ET tube out. On day 2, he was evaluated by the psychiatrist who maintained the Baker Act. And they specifically speak to the fact that this patient has zero psych history, and only substance abuse history. And this is from their note. And I will further caveat this, because I know it mentions alcohol abuse specifically. The patient's alcohol level on this day was 25. The legal limit is 80. So based on alcohol alone, he was still very capable of driving a car. Like, you get an alcohol level of 25 from less than one drink. So he did not have a lot of alcohol in his system.
What about anything else?
He definitely had cocaine in his system.
That's it?
I mean, he had benzos in his system, but like, guilty, we did that.
Is that why everything was so elevated as well?
Say what?
Is that why everything was so initially elevated though?
I still didn't hear you.
Is that why everything was initially so elevated too then?
Why?
Blood pressure, heart rate.
Very possibly.
That's all they found in his system.
Little bumps.
What else do you see?
I thought there would be a mixture of cocktails of,
Now,
Drugs in his
admittedly,
system.
like, there are a lot of drugs that we miss.
say that again?
There are a lot of drugs that are missed on drug screens.
I truly believe that that's not the only thing going
I
on.
was about to say, but methamphetamines, if that's what you're thinking, is not one of the ones that we miss.
Okay. There still could be a lot of other, I'm just.
So on day 3, he actually had the chest tube removed. His pneumothorax was fairly small, if anything. So they were able to get the chest tube removed. On day 4, they got the drain out of his neck. And on day 5, from a medical standpoint, he has been stabilized. So they said that he is safe to go to an inpatient psych facility. And on day 6, they managed to make that happen.
Day 7, he returns.
It literally was 7 days later. Was this also on y'all's shift?
Yes.
Okay. So on day 7,
Wanted to hang out with everybody again.
this was also you? Okay. What's that? Okay.
Who transported the second time? Yeah.
So 7 days later, this happens. What's jumping out at y'all?
Say that again.
What's jumping out at y'all? Anything? Nothing?
This is a top 5 report.
Say what?
To see.
There are a lot of comments, but I can decipher almost none of them.
What he used to do it.
Oh, I have a picture.
Oh, great.
It was included. We can make it match too. It's actually pretty fascinating. These are vitals.
Gee.
Anything jump out to y'all? It's got some pretty significant tachycardia. Yeah.
Back home again. Yeah. Bad batch.
Straight nicotine, GCS.
His blood pressure does start coming down over the course of this. Yeah.
GCS also decreases.
I was
Did he
gonna say,
succeed this time, or are we gonna be running him again?
He is still alive, if that's what you're asking.
So a couple months, we'll be out here again, run this.
Is it what?
Fired again from his job.
Yeah, especially if he gets
So
fired
let's talk
again.
about his blood pressure for a second, because it does come down. But let's also show you this, so to potentially put it in context. He got given ketamine, so now let's think about his blood pressure and vitals in the context of the fact that he got ketamine.
It's the old dose of ketamine.
Say what?
The old dose of ketamine.
It's a generous dose.
The respiratory rate went up after you get the ketamine.
It's 4 milligrams.
Or it stayed about the same.
what?
4 milligrams.
To be fair, both protocols are still live, so we're still good, but this is the older dose of ketamine. I was about to say, what would be the new dose of ketamine for this guy?
Say it out loud.
4 milligrams per kilogram.
He was 162 pounds. Or about that.
72.
280. 280.
Before.
So it sounds like we're at like 280, 290. So I'd say y'all are doing some really complicated math in there. I'm rounding to 300. But yeah, sounds good.
Look at me, pal, I have no.
So now let's take a look at his blood pressure and his heart rate in the context of ketamine. So what would we expect somebody's blood pressure to do with ketamine?
Stay the same.
So I'd say go up, go down, or stay about the same.
We'll say about
I
the same,
wouldn't
maybe go down
expect
a
it to
little.
drop like that.
I would expect it to stay about the same, and if anything,
Go up.
maybe go up a little bit. So now in context, that drop in blood pressure is much more concerning given the, I can't blame my medications for this. Like, if anything, my medications would have helped with this. Would have prevented a drop. And it went down, okay? Now let's look at his heart rate. What happens with his heart rate during this time? Yeah, it's kind of about the same. So what would I expect ketamine's effect to be on somebody's heart rate? Go down or stay about the same? Yeah, I would expect it to go a little higher or stay about the same. So I have his blood pressure and his heart rate coming down. This may be partially from the sedation itself that his heart rate is coming down a little bit, but if I tell you that somebody's heart rate and blood pressure are coming down in the context of hemorrhage, that's bad news. It's impending bad news. Okay. Okay. This is our assessment. Actually, really nice an assessment if I ever did it. Easy.
Oh no, it's self-proclaimed top line.
Yeah, I don't know that I put this in top 5, but it's not bad.
Use number 5 right here.
This was almost.
All ones.
Is that what you're getting at?
I actually I don't mind the ketamine in this case.
When in doubt.
I will caveat that one. And I actually don't even know what they're gonna say, but if you guys are interested, there is a webinar being put on by Rich, did you get this one?
Set it up in the hospital, 2 medics, so we can get in trouble.
Yes,
Yeah,
the Elijah
that's
McClain
the reason
case.
why I was asking you, that's why you didn't finish.
Well, and I have not heard this webinar. It is gonna be live today, curiously at 1:30. If this is something that you guys are interested in participating, I can send, I don't know if you got the email about this one.
Which one is it?
It is a webinar from, I always wanna call them, no, it's Wolf, Parkinson, and Worth, right?
WTW.
PWW. But they're specifically EMS lawyers, and they're talking about the Elijah McClain case. And I have no idea what they're gonna say today, but I wouldn't be surprised if they would caution the use of the words excited delirium in documentation, just because it's so much of a firestorm right now. It doesn't mean that it's not accurate to the situation, but just those words, I think, tend to set people off right now, and it's probably not worth it for those 2 words. Just describe what you're seeing and what the actions are, and then you're covered. That's what I suspect it'll be.
Is that because like it's not officially a medical diagnosis?
There is a lot of controversy around it, so much so that the American College of Emergency Physicians has actually moved away from the term excited delirium, and they're calling it hyperactive delirium with agitation. And if you're thinking to yourself, like, those sound very similar, yeah, it doesn't change the fact that, like, the constellation of symptoms is happening. It's kind of just a rebrand, because the term excited delirium is being used, 1, colloquially, and then 2, inappropriately. I think the safer bet is just don't use the words, describe the behavior. Was one of you on this call? What was he doing?
He was fighting us, that's why I got that.
I was about to say, that is easily defensible. He is actively trying to punch EMS personnel and the police, and then you can describe the behavior, and then of course, safety is a priority, and we can go to, but like.
Patient was medically sedated for safety through intubation.
Yes, but you can always say that, but describe the behavior that prompted it. As long as you describe the behavior that prompted it, like, I don't think this guy is literally armed. He has already stabbed himself, and now he's coming at us and the police. Yeah, like this one's a no-brainer. Like, the use of ketamine in this case is a good idea. I think from just a solely documentation standpoint, you are safer in your own practice by describing the behaviors than by using the words excited delirium.
Can you put like manic state, like they were observed in some sort of?
Yes, but they're gonna crush you on that one, and what I mean by that is, because this guy wasn't manic, like mania is something very specific, and it's a specific like mental illness diagnosis, which at this point in time he carries no mental illness diagnoses, just the substance abuse. You're safer either way, just describing the behavior that you're seeing. Now, if you describe the behavior and say like concerning for mania, you're gonna be covered. That way you're not like saying this is definitely mania. Just describe the behavior. Like this is unsafe behavior no matter how you slice it. Cool. Yeah, I think this is a nice assessment. And I will comment on, I think it's really nicely done that they not only comment on the wounds that are new and the wounds that are old and freshly opened versus the wounds that are old and still shut. Review assessment. Narrative. Thoughts? Say what? I actually think that's a really good point,
What?
what you just said.
ANO times 1 with the PCS of 15.
Because you cannot be that.
Right.
If you're ANO times 1, what does that make your GCS?
3.
Not necessarily. Yeah, Matt, 14.
Said center.
You're -1 on the verbal. You're -1 on the verbal, it gives you go 14. Any other thoughts, comments, concerns?
Insane, is it?
You watch the other one?
Unless it was the hospice status.
Somebody had an email with 3 steps that you did.
Yeah.
Very simple.
Start one, AP extracts, then
I'll just wait.
So there were a few pictures attached to this chart. One is this.
Good God, the big one.
Okay.
Nice.
Locust picture.
And I actually, like, I will comment really briefly on, like, it had said in the chart that these were hedge trimmers, but nothing drives this home like seeing what we're talking about. I'll admit, I don't know how onerous it is to snap a picture and attach it to the chart, but if it's not hard, dude, like, this drives a message home. And most importantly, I want you to pay attention to those blades, because they will come back up. I also got this picture.
Yes, sir?
So this would be the largest of this patient's wounds. Okay, he goes to the trauma bay, where he has obviously a head CT that's done. It looks like this.
Oh, you went there.
So, let's talk about like what we're seeing here. So, bright white is his skull all the way around. As you actually see swelling here, you can see how like, you can see how like this skin is like nice and tight to the skull, so like you don't have a lot of fat on your head. So it's nice and tight to the skull all the way around, save from here to like about there. And you can actually see that it kind of does a little wobbly thing, like right around here and here. And that's just because the skin is kind of like tenting in weird directions, it's pooching out, it's pulling inward. And then I also want to point out this part of the CT right here, which I realize you're probably thinking is nothing. But what is this part of the CT in real life? What fills this space? Air. And this looks exactly like that, and that, and that. So he's introduced air into his own skull. So these, just like this is bright black, these little spots here are also air. Yeah.
When you're telling your active so you think that's an organic issue in that?
I don't. I think he's just.
Does that create some sort of bad pressure?
Not necessarily, because remember he's got his own relief valve. Like you guys got to see the picture. He's got a little wound right here. So whatever has the potential to go in actually has the potential to come out, and that actually makes it so that head bleeds with people with skull fractures are less damaging. Again, I guess we'll talk about. That's actually one of the reasons that suicides via like GSWs to the head are sometimes really prolonged, because yeah, they're having bleeding and injury in their skull, but they've also done their own craniotomy, so now they will have a free-floating flap of bone, and so they'll never mount the pressure in their own skull to kill themselves. It's not ideal. And the reason I actually was so pleased to see this picture with the picture in our chart is this bright white within the brain. So now we're looking at this pattern here and here. If you're looking at how it creates that, there's like that one little edge that comes out here, one edge that comes out here. It looks surprisingly like a blade. It looks exactly like this. Yeah. Now, admittedly, he probably got himself through some of the thinnest bone in the body, which is right around the temple. So yeah, he's got blood all in here. These like, you can see these are kind of like streaks of white along here. This is also blood on this side, so this little area is blood right here too. So he's got a bunch of blood and air in his brain. And this picture isn't the best, but, oh, this one does okay. This is another slice through just a little further down on his head. And you can see how this skull is bright white. Like a pure bright white. Even the bleeding is not that same like intensity of like white. But this section right here is that same bright white. He literally took a chunk of bone and literally like shoved it inward.
So pain is a healthy treatment.
So, again, he was cutting at his neck. So they did some studies to look at the blood flow going up to his head, neck, and brain. And these are reconstructions of the blood vessels running up through his neck. I left these little designations here. So this is the right side of his body, the left side of his body, and just like it's slightly angled so we can see all the branches. But you can see down here you have his aorta coming up and around and then down, and then your branches coming up. What I want to point out on this scan is this little area right here, where he didn't actually manage to cut through his blood vessels, but they are so mad that they've actually started to vasospasm. So there's a good chance that he got really close to the blood vessel, hit it hard enough that that vessel spasmed up, and so it's actually contracted right along here. This is what happened in the trauma bay. This means subarachnoid hemorrhage. And just like you guys saw on the previous one, they gave TXA. So his GCS got a little bit worse while in the ER. He went from a GCS of 9 to about an 8, and they decided to intubate the guy.
Would that have been in part to the ketamine that was given on scene?
It's hard to say. I would have a hard time believing that the full effects of the ketamine had not been fully in effect at the time that he arrived in the ER. What I suspect it is ketamine plus whatever substances he was on, cocaine, started to wear off a little bit. And so while ketamine plus cocaine was amounting to a GCS of 9 before, as the cocaine wears off, we just have ketamine, and that becomes a GCS of 8. And so, like, I mean, did the ketamine contribute? Yes, maybe. Well, not yes, maybe. Yes, it did. But like, is this the one distinguishing factor in this? No, I think this would have potentially happened anyway. Besides, they're not going to mess around with his GCS decreasing anyway, because at this point in time, yes, we gave him drugs. Yes, the patient already has substances on board, but he also now has a head bleed. And so out of all the things that could potentially be, I'm gonna bank on head bleed before anything else. And so they'll be aggressive with his airway. So now he's hospitalized again, this time for 11 days. So on day 1, he had the wound repairs that were actually done at bedside. And in addition to the CT scans that were done of his head and neck, they're planning to redo these on day 7 to see what's changed. Of course, they'll repeat them sooner if anything traumatic changes in his mental status or anything like that. But particularly that area that you saw with the vasospasm where it was like clamped down, I expect that to get better over time because there's not an actual wound. On day 2, psychiatry was consulted because again, he's under a Baker Act. They couldn't talk to him because he was intubated, but at the end of the day, the patient was actually able to be extubated. His mental status had improved. On day 3, this is the note from psych.
Basically, when he drinks and he does some cocaine, he has bad judgment.
I was about to say, and if you're reading the note that way, you're not wrong in what they're saying. Like, again, he has no previous mental health like disturbances. This seems to be when he is on drugs and alcohol. And again, if you look at that alcohol level, his alcohol level on admission was 60. He can still drive at that level, y'all.
Bad judgment when he's on cocaine.
And I think that that's probably more accurately it, is cocaine can give you some incredibly powerful hallucinations and delusions, and yeah. I'll admit, I'm kind of skeptical that he drinks as heavily as he says he does, because the person who drinks 18 beers a day, when they get down to an alcohol level of 60, they withdraw. And this guy wasn't withdrawing, he was like,
He's full board.
he really was. So like, he wasn't withdrawing at this moment. I have a hard time believing that, even on the previous episode, when his alcohol level was 25, that, I mean, he wasn't intoxicated then, he was, he doesn't meet the legal definition for intoxicated now. Like, he has alcohol in his system, but like, again, this man can drive. This is less than 2 beers in his system. I think it's the cocaine. Now,
So is that the only thing they found was the cocaine?
Mhm.
No like PCP, no. Wow.
I was about to say, the first time they found benzos, but like, we were guilty of that one. Like,
Yeah.
we gave him benzos, so you can't
Yeah.
you can't blame the guy for what we potentially did. Not to mention that benzos probably doesn't cause this constellation of symptoms. Cocaine certainly can. And then they comment at the end here about, like, okay, this is a guy who is already demonstrating exceptionally poor judgment by 1, cutting his own throat, and then 2, stabbing himself in the head. But now he's also gotten part of his frontal lobe. And what does our frontal lobe do? Say what? Yeah, I mean, it can help you with moods, and specifically like thoughts and judgment and action. So like translating those moods into like what you do with it. And so now we have a guy who's already struggling with judgment and impulse, and now he has damage to his frontal lobe.
We're really gonna make poor decisions on cocaine.
Well, it could do one of 2 things. It could either amplify those bad decisions or really tamp them down. God, I didn't expect today's, like, all the cases to be about suicide, but there was another guy who tried to commit suicide, and he did so by using a nail gun, one in his chest and one in the front of his head. And as we're riding into the ER, I'm talking to the guy, and he's just super flat. And like, not like depressed, like he's just completely apathetic to the whole situation, to his pain. It was, so I think that's from the frontal lobe injury.
Come on, Nate. He went to the bathroom, yeah.
Is that what that was?
Yeah, that's what it was.
It up, I was
Yeah.
like, are we going or?
He's like, oh, that's in my district, let me go to the bathroom.
It's us, I need 103 now. See ya.
You want me to continue or? Okay, so in the hospital on, like they talked about, day 4 through 6, they're really just monitoring more for changes. You didn't really have any. On day 7, we got those repeat CTs of his head and neck. This is the repeat CT. And if you're thinking to yourself like, oh my God, that still looks bad. Yeah, it does. So compared to the previous one, you're still actually, and I actually think we can arguably see the shape of the blades better as they had like entered into his brain. So you see the shape of the blades, you see this kind of like black area around it. This is areas of swelling. So he is having some swelling. The good news is it's not huge swelling. Again, he has his own little relief valve. Now you can actually see the pathway out to the not out to the outside world, but he's got a break in the bone, and you can actually see the break in the bone. And then you see a lot more kind of like uniform swelling out here. The blood vessels before, where you saw that they were all like ratty and raggedy and had those areas of like spasm and whatnot, now they are beautiful and pristine. And then this is the final note from psychiatry in the hospital.
So this guy has no deficits.
Correct.
That's crazy.
Now, I say no deficits, it is really difficult to interpret personality changes.
I'm
So
talking about,
like, no, you can move
that's
everything.
crazy.
Now, this all depends on like kind of like where he hit his brain. So if we look at this, your movement is going to be more here and here. That's also where like your speech areas are. So he mainly got the front part of his brain, and so that's in turn, like that does your personality, your judgment, like it turns your thoughts into action. And so it'll be difficult to quantify what is a deficit in this area, other than to speak to his family to see if he's still the same person that he was. Correct. And that'll probably also be difficult to determine because who you are is different than who you are on substances. And so he's been on drugs for several years now. So we got several things influencing his personality and his judgment. So what is his baseline versus what who he is afterwards? It's gonna be tough to pick apart and put it on one thing. So at the end, again, he still carries no primary psych diagnoses here. And they didn't give him any here. They didn't give him any psych diagnoses, but they started to think on the idea of maybe there is a primary psychotic disorder that is
Maybe.
being unmasked by the cocaine.
Maybe.
Admittedly, it's hard to tell these things without people being off substances. So until he's off substances, it's hard to pick apart what is drugs versus what is a primary mental health disorder. And so that's why they're still kind of hedging here.
They're waiting for that third time.
Yeah, so even if you have 2 rounds of suicidal attempts, obvious psych history in that, but whether he's on drugs or not, they still don't give some sort of psychiatric, they just say cocaine did it, she's under the influence.
Potentially cocaine did it.
Substance.
Now, undoubtedly, cocaine can do this.
Right,
Um,
but there's plenty of other people that do cocaine and aren't trying to cut themselves with box cutters and hedge clippers.
true.
They just, at what point do they say, all right, this guy's got some sort of psychiatric problems going on underneath?
So that'll all be based on like who, like, does he meet the like diagnostic criteria for these other psychiatric things? And I will say on the surface, like, I'm not seeing anything like obvious that he would meet qualifications for, because his behavior doesn't fit with like I mean, we naturally think about like depression associated with suicide attempts. And it doesn't seem that like his pathway follows the usual course for somebody who is depressed and trying to commit suicide.
Well, one
Sorry.
statement did say he was like recently released from his job and having financial issues, right? It's a normal thing for people depressed over. Did it say,
Or start
well,
using
after this
substances
time, was
or-
he just Baker acted again, or?
He was Baker acted in the beginning, and that's actually what happens here, is on day 8, 10, they start working on inpatient psych placement, because that's where they're gonna start being able to like pick apart, like, the hospital is really just for the medical stabilization piece of it, and now we're gonna do like the psychiatric work, so now's when we're gonna like detox from all the substances, really start picking apart like what is the cocaine versus what is a primary psychiatric diagnosis, and on day 11, he goes to inpatient psych, and I don't have any more on this guy, other than he does show up to the hospital for a finger injury, but like, it was a standard finger injury, it wasn't like a self-injurious thing, it was like he had like a little scratch or something that got infected, like,
So
it
he's
wasn't a crazy thing.
He's not still in like any sort of inpatient facility?
I know at some point in time he made another visit to the ER. To be fair, I didn't look into whether he was in an inpatient psychiatric facility and they brought him in for medical evaluation. I'll admit I didn't look at that and I should, but it didn't, I looked at that visit briefly and it didn't seem that that was the case.
So even during his first stint under a Baker Act, they don't evaluate you then for psychotic episodes when the
They
cocaine is
definitely
worn off?
do. Now, I'll admit, I don't have any of the documentation from the inpatient psychiatric facility, and that was actually part of the reason why it took so many days to get him placed, is one, psychiatric facilities are few and far between, and this guy actually had to go pretty far for the second placement, because psych facilities are just so limited. I would say in the state, but it's actually fairly true nationally too.
You said he went pretty far though?
Mhm.
Like where is it, do you know?
I know that it was like, I think it was, if I'm remembering correctly, where the facility that I think he ended up at, there's a list of like 25 facilities that they contacted, and either they didn't have beds, they weren't available, they like, for whatever reason, like we couldn't get him placed there. There was at least like 25 or 30 facilities that they checked with, and basically they'll start local, and as like you get no's from people, you start like expanding your search. It is not uncommon for patients with like serious psychiatric concerns to go 4 or 5 hours from where they were.
So this guy's Miami-Dade's situation now.
He went north, but
but.
he went north, but yes, he did go to an inpatient psychiatric
Yeah, but he
facility that was not here locally.
But you said he checked back in here, or like for a finger injury.
I mean, he
Here?
lives here. I mean, he
Like
lives
Lee
here.
Health. So that means he's back in.
Both of his
Yeah, I
psychological
mean,
assessments.
at any given
it
time,
said
they
he
can
didn't have,
Let's do
cognition
it.
of his
No,
decision making as far as the suicide attempts. Is
Mhm.
that not a diagnosis in itself that you don't realize it's a bad thing to slit your own throat?
It is difficult to say what makes that the case, though, and particularly after the second one. Because I was about to say, what I didn't well capture here is on the after the first attempt, they comment on how he was remorseful and he saw that like he commented on like oh, I shouldn't do that, I shouldn't do drugs. That those comments were there the first time and they were not there the second time, and so it's hard to pick apart like what is causing that. It could undoubtedly be the injury and the frontal lobe damage. It could also just be like, this is the psychiatric disease progressing, and this is him trying to get, like, all part of the psychiatric disease. It's hard to say what is what. But they did specifically comment on the second time he had no insight into his actions and the consequences of his actions. The first time, kind of, sort of. Yay. Such a dark least like 2.5 months, and he hasn't tried to kill himself yet.
Might have fixed himself, honestly.
That we know of.
Yeah, I agree with that.
To be fair, you guys knew the first two in a very splashy way, so I have a feeling you guys might have picked up on the third. But yeah, fair point. Okay, case number 2. Okay, so now we're going to be talking about a 45-year-old male, 230 pounds, who was involved in a motor vehicle accident. I believe it's a motorcycle. I see you squinting so hard on that road. Do you need glasses?
I have them, I don't have them on.
Okay.
He doesn't think they look cool.
You look cool. So I'd say, was this y'all's case too? If it, okay, I was like, this was y'all's case. Remind me to never come out here on, what is it, Tuesday again?
Just on the board?
This was when?
He should have in front of station 1.
Oh.
This is what I got in terms of vitals and history.
Okay.
A lot of people admit defeat in scoop club.
That's not a good GCS.
It's not a good test, no.
So what score you can get?
Yeah. It's also a fairly narrow pulse pressure in terms of his blood pressure, in that, like, yeah, he's got an elevated systolic reading, but he's also got a pretty elevated diastolic reading, particularly, like, a diastolic of 106, I don't get too bent out of shape about if my systolic is like in the 200s. Like, those numbers match. There's enough of a difference there, but that's a really narrow pulse pressure in that, like, his diastolic is really high up compared to his systolic. How about his sats?
They do anything for it to come up to have on oxygen?
They
Or does the
did.
oxygen there yet?
They did. Big thing. But yeah, his
They
stats
weren't
get
bagging
better.
him or anything?
They definitely would have to at some point, yeah. Here, let me give you this part. There is a ton of information here, so, yeah, so we got both Accommodate and Rock going. Okay, admittedly, leave this phone.
So now that we know they did RSI,
Uh-huh.
the initial SAT was 90,
Uh-huh.
the pre-oxygenation wasn't adequate before they started RSI. I mean, the time was what, 1836, 18.
What is hard to place in this one, and admittedly, like, this is sometimes like really difficult to capture, is what was our starting SAT versus like what we actually capture. So if his starting SAT is 70, for example, and we got all the way up to 90, I'm pretty dang happy with 90. Now, there are also patients where if you pre-oxygenate them, and they're sitting at 90 and sitting at 90 and sitting at 90, and you can't budge off a 90, sometimes 90 is the best you're gonna get. The real question is, like, did they do the adequate pre-oxygenation? And that is difficult to answer from this. It is difficult to, actually, I would say that it is less difficult to answer from this because of this piece. They were BVMing the guy. So I don't know what he was at first, but if you get a 90 with a BVM, yeah, you're probably doing pretty good. I can't speak to how long they did it, but you guys have also seen in like the RSI process, it just takes a little bit to set everything up. So,
Did they do it before on scene, or did they do it like once he was in the rescue? Do we know?
He did it on the street.
I was gonna say, I can't vouch as to whether there was metal over their head, but they did this before they were rolling.
He's in the street.
This one, the tracker's on it. This one.
This is the call the tracker went on the
That's
camera.
how
What street was this on?
Huh?
What street was this on?
It's in front of Station 1.
So there's also a ton more information in this flow chart. So what else did we learn about this patient, or what happened to them or didn't happen to them? So-
Bilateral EOB compressions.
Yeah.
So continue to have resistance when they're bagging.
Yeah, so this, like, I was gonna say, sometimes the flow chart is just like, oh yeah, they did these 7 things. I was gonna say, whoever put in the details on this, like,
It's really good.
ooh, like, I know exactly what happened and like why the decision making on this one is fantastic. Cause I know why the decisions were made, and like I can see the flow of that information. It makes really great sense. And there's, I'm not saying this is the right way to do a chart, but there are plenty of ways to do a chart and do it your own way, but like, whoo, like, I know exactly what happened on this call. It paints the picture, and that's really what we're aiming to do, is paint the picture about what happened, and so, success. So yeah, they intubated the guy, they did so successfully with, mind you, a massive tube. And then as they were like bagging him what the tube is in, with good waveform capnography, by the way, they were meeting resistance. So this was, yeah, they did venal decompressions bilaterally. And do we think that that was the problem?
Yes.
Yeah, I do.
So they didn't have resistance afterwards.
Yeah. Which side do you think was the problem? It's gonna be that left side. We got that big old rush of air. And then all of a sudden he's bagging better. Fantastic information in here. This is our first assessment. This one paints a lot the same picture as the flow chart actually, and so it's very consistent in terms of the information that's there. This is the rest of the assessment from this one, because if you notice it cuts off at pelvis. This is the rest of this assessment.
Look at that, they got cap refill and everything on this bad boy. Good for him.
Can't tell if you're being skeptical in this case, or.
No, I don't, no, I think this guy did a really good job. Really scripted.
I was gonna say,
Person.
you know
Lay down.
exactly what's going on with the patient, like this is, don't get me wrong, this was probably a beast to write out, but like, I don't know what's going on with this guy. This is the narrative.
paramedics in direct patient care. Really covering all the bases.
I think they were a little nervous, but that's okay. I mean, if they had two paramedics, like, and this is like, and I'm sure they did, based on the documentation, I know there were two paramedics there, like, it's accurate as details, like, okay. I'm not sure that they definitely expected their case to be up on the screen today, but like, dude, like,
They were prepared for it.
they were ready, like, this case is so well documented. And then unfortunately, when the patient got transferred over to Leaf Light, I have like zero information to identify this patient off of. I can always do it off of an incident number if I reach out to Leaf Light to find if they got the patient information. But I couldn't track it back to the hospital, so I'm sorry, but I don't know what happened to this guy. And it wasn't attached to the outcome on our end because of the Leaf Light. So the only reason we had the previous one is because we knew the guy's name and we were able to like find it off of a variation of his spelling, the variation of the guy's name spelling.
Yeah.
There's ways, but I didn't have I would not have had the turnaround time to reach out to Leaf Light to identify the guy to then look the guy up, so I'm sorry, I don't know what happened. But, oh my god, like after reviewing both of these cases, I was just like, holy moly, like we're doing really great with our RSI use. So these are both ESR cases, and so I was like, yes! And so like, I'm just so stinking proud. Now if you're thinking to yourself like, hey, but we didn't get one of those. Like, there was an RSI case that we got and an RSI case that we didn't get. I'm still so stinking proud of both of them because we'll never get 100% of our airways. But if you're gonna miss an airway, what do you gotta have? You gotta have a backup plan. And so, on the case that we didn't get the airway, did we employ a useful, adequate backup plan? Heck yeah! So that's perfect. That's exactly what we would want. And I'll actually use myself as an example. I was about to say, nobody who's good at intubation can boast a intubation success rate of 100%. Ever. Period. It probably, if you can, it means that you haven't done enough airways. Because eventually there will be one airway that like you just can't get. It's either not gettable or circumstance. There will be plenty of reasons why you aren't able to have a intubation success rate of 100%. And so the real, what makes somebody good at airway is having that backup plan and being able to employ it and knowing when to use it. So I'm so stinking proud of both of these cases for that reason. I'll spare you guys the details of my airways recently, but like if you guys are interested in hearing about the details of it, I'm happy to go over it with you because it is humbling and also important to like realize the importance of a backup. And then the only other thing that I would point out in these cases is the use of TXA, which, do we know when we're gonna get it? Okay, no. Okay. In both of the cases with the suicide attempt, he got TXA. And I wouldn't be surprised if the second guy got TXA either with Leaf Light or at the hospital. Just think about it anytime your patient is having life-threatening levels of bleeding. The only one that I would say is a little bit like, I don't want to say controversial, was the one where the guy stabbed himself in the head. Because remember, isolated head bleeds don't have good outcomes with TXA. But if you're still having heavy bleeding in association, like if you have both injuries to where he's like bleeding profusely from the neck and he has a head wound, yes, still TXA because of the bleeding from all the neck. Okay. How old was he? So now we're talking about a 74-year-old lady who weighs 165 pounds, and we got a call out for sick leave. Took a turn. So thoughts already. So I'd say, was this the one y'all too?
in the bathroom.
I mean, the only way for me to know it's in the bathroom is if somebody wrote down it was in the bathroom. Thoughts? Anything jump out at y'all?
Must be out too.
Yeah, it's kinda marginally.
I feel like sometimes though, with like the pediatricians we have, they don't get good pleth readings anyway, so I feel like half of these, they're not, you're at 97 at one, 90 at the other, 98, 90, 95. I feel like that's something like, sometimes in my reports, I'm just like, dude, you get a good pleth reading and then it takes a blood pressure and then it's not reading correctly or whatever. I don't know.
You're not wrong. I would say overall I would look at like a trend. And so like if there's like, if you start at 97 and by the end you're like at 89, 90, it's showing like an overall trend. But this one does one of these. So like, I like that we're keeping an eye on it because they are marginal. But I agree, like it's hard to make heads or tails of this. I don't know if it's going in a particular direction or not. Any other numbers jump out at y'all?
46 heart rate.
I was gonna say the one.
The 46 I got kind of like an eyebrow raise about, but like, also, I don't know if it maybe it caught like a weird moment, like,
I've also seen SpO2 say it was 50 and then the guy, we put him on a 4 lead and it's 160. So.
I will say with heart rate, I was about to say, be aware that your monitors can do this.
Yeah.
It can double count or half count depending on the morphology of the QRS complex. So if you have, the easiest one to probably explain is double counting big T waves. So if you have somebody who has a QRS complex that looks normal and then a T wave that is big to the point where it almost looks like a QRS complex, a lot of times your monitor will double count the heart rate and it'll, like even if the patient's heart rate is at 75, the monitor will say it's at 150. You can do the same thing on the slow end, is if things are fairly flat, it'll just miss beats entirely and just not count them. I'm not sure that was happening here, but it can happen. So we did for this patient. Let's say they did something about your oxygen there. So yeah, they were worried about it too. They were like, oh, I don't want to be going through them, doctor. Let's do some mesothelioma.
This was your call, Pierre?
I was about to say, if you guys are recognizing from what's written down already, like, whoop.
Yeah, Barry says he's
I
not.
think I was on this one.
You just got 5?
No, I don't remember who the medic was. I think I was at 105.
Switch from there.
This isn't mine.
No, this one's.
I do same.
So say this is the assessment.
The way it came in, syncope to stroke. That's what
I was
I
about to say,
was in the bathroom.
I was about to say, you guys may be able to distinguish a little bit more when I give you the narrative, so it's coming. I do always struggle with how to like orient the pieces, cause some of them make better sense, but they give away the story. It's a narrative. Looks like it wasn't in the back.
It was gonna bomb.
That's what I'm saying. Well, it's gonna.
Gonna bomb.
Is that Delaware?
That doesn't sound kind of like what you do.
He said he let it
Gonna.
go 5.
Gonna bomb it.
Gonna. I used to say OT, and I know.
Bruce, what happened, where are we?
They're laughing at the top sentence.
Oh, wow.
You're a little weak, you're
First
gonna.
sentence.
It did seem a gun, huh?
Good.
Or off. Patient tells a mistake.
Look at horror movies. Bruce, what happened? Bruce. Oh.
I think. I mean, it makes sense, I don't know if I would be writing it that way.
I would say about abbreviations, either use abbreviations that are common or abbreviations that you undoubtedly know what they mean yourself. Ideally, they'd be abbreviations that other people understand too, because that's the whole point of a document, is to communicate information. But as long as you be able to get up on the stand and say, I definitely know what I wrote there is X, then you're good.
The
Unrivaled
sentence.
house.
And then there's another, there's another mistake, oh, here, yeah, that's good.
Oh, I read that as on arrival found female patient.
Oh, yeah, the female.
FM is female and then OT is a misspelling of PT.
Yeah, and then he did it again in the page.
TOT, yeah, that's it.
Turn over two.
Yeah. Yeah.
TLT, RCBTV.
I was worried about reading it.
I would say on,
That's weird.
as far as like using abbreviations and like cutting corners on spelling, there's no problem with it, but like, think about how you judged this call differently based on the word gonna. I was gonna say, all of a sudden it colors literally everything else that you have read. And it doesn't mean that it's not accurate, but it means every choice you make.
Put it in quotes.
Yeah, at least do that.
She probably didn't say, I'm going
Well,
to vomit.
They were gonna put it in quotes, but they didn't.
They did manage to put Bruce what happened in quotes, and
Yeah.
that's nice. So, a lot of good information captured here. Y'all are always much harsher critics than I am. So this patient goes to the ER under a stroke alert. And this is her scan. And I will say for she's what, 74 I think I said? For a 74-year-old lady, it's a pretty good looking scan. Pretty healthy looking scan. As people age, these little like dips into their brain, these little sulci get bigger, and like, this is pretty few sulci for somebody who's 74. So this is a pretty healthy looking brain. You do get a little bit of it here and here, but like, pretty healthy looking brain, no bleeding, most importantly. And this is the ER doc's neuro exam. What was that face for?
So she did not have any facial deficit? Never mind.
To be fair, that no focal deficit is probably in their like they probably have like a set exam that they put on everyone and then change the abnormal thing. They probably missed that no focal deficits because they go on to describe focal deficits.
Right. Change it to 3.
So, just like you guys do, like if there's something that you use regularly and copy and paste it into exam, like it's the same thing with drop downs. Like just be careful with like the contradictions because yeah, like you can pick them out immediately. Like this patient undoubtedly had focal neurodeficits. This was just in their prefab answer. Okay. So she goes into the hospital for the stroke alert, and this is actually the HPI from the ER doc. She was not in the bathroom. Yeah, she goes into the ER, the ER doc agrees, this is a code stroke. They do the original CT, they show no bleeding, so she's a candidate for TNK, which is the clot busting medication. And they give her that and some medications to control her blood pressures. On a repeat scan that looks specifically at the blood vessels, that's the CTA, they see that there's this area, a small occlusion at the right vertebral artery. And so that's what they think is causing her stroke. And then after she gets the TNK, she starts getting better. So she gets admitted to the hospital. And within 1 hour of getting that TNK, she starts getting better. And then right at around shift change, the note isn't at 19:27, but it sounds like the changes started to happen at about like 7 p.m. They note subtle but changing symptoms. The now hospitalist goes to see the patient, and the patient was actually curiously getting a scheduled repeat CT at that time anyway. And this is what they see. So this does not look like the previous one. And like we talked about on the previous scan, this area of white over here is actually bleeding tissue. So this is bleeding, and this is actually probably a better case for you guys to see what is midline shift. So when we talk about like shift within the brain, if you draw an imaginary line from this point here, which is the midpoint of the front of the brain, and this point here, and then this is the back point of the brain, and I draw a straight line from here to here, you can see that like it doesn't match up with the midpoint, it kind of like pushes over a little bit. That's actually what we're talking about is midline shift. She doesn't have a ton of it, but it does exist. So day one continued. She had that improvement with TNK that was given at the 15:10, and then had these subtle changes, and then they got this repeat CT scan that now shows hemorrhage in the actual tissue of the brain. They consulted neurosurgery, and neurosurgery says nothing to do right now. It's hard to drain pockets of blood that aren't well defined, and then be not causing a ton more symptoms. Like her symptoms were subtle for them. Because remember, anytime I'm going to cut into the brain, I'm going to have to forge my way there. And so I'm potentially going to harm more tissue to go in after it. On day two, the patient is combative, and they were trying to get a repeat CT, but she's just fighting them a lot, so they had to put her on some medications and do some restraints for safety. And then her CT that day looks like this. So, certainly she has a little bit more definition to the bleeding now, because now we're looking at this area, this white area is more defined, it is more obvious where the bleeding is, and isn't compared to before when it was kind of fuzzy-ish. you see a little less of the shift actually, so if you follow that imaginary line, there is a teeny tiny little bit of nothing shift, but it's there. And so what they called it is, the radiologist says the bleed is mildly worse. Neurosurgery was like, nope, looks the same to me, it's just more defined than what it was previously. And the patient had actually improved clinically at this point in time. She was no longer agitated or combative. They were able to get her off the medications that they had her on. So they were just gonna repeat another scan. On day 4, she was moved out of the ICU and she was evaluated by physical therapy and speech therapy. They're definitely recommending inpatient rehab for her now that she's had this bleed. Day 5, the patient was initially refusing rehab, but then became agreeable to it. On day 6 through 8, they were waiting for insurance approval. Yay, US healthcare system. And then her last repeat scan is actually clearly improving. So now what we're seeing is that area that was well defined with bleeding before is starting to lighten. This will happen anytime that we have bleeding. Bleeding that's a week out tends to be about this color, like usual brain color, so it tends to be actually really difficult to identify. And you can start seeing that here, like this has started to lighten. This black area, just like before, is that area swelling surrounding any injury to the brain. And that's it.
So she was taken out to T in case, and they didn't give her anything, and she just got better.
And admittedly, like this is always like the risk that we take with a stroke, is who to give that medication to, because brain bleeds are a known side effect of it. And particularly, the argument is kind of mixed. So if it is definitely a stroke, your risk of getting TNCase is actually higher than if it wasn't a stroke to begin with. So let's say that I'm looking at 2 patients and they have similar presentations. One is a stroke and one isn't a stroke. If I give both of those patients TNCase, the one who isn't a stroke will less likely have a bleed as a result of it. The one who actually is the stroke and could benefit from the medication is the one that's more likely to bleed, because there's also more likely damage to their blood vessels. So it's a double-edged sword to where like this can cut better and get your stroke better, but it also increases the risk of bleeds. It is also true that the larger your stroke, the more likely this medication is to rescue you, just like the larger your stroke, the more likely it is to cause a bleed. It's an imperfect medication. And that's also why you guys have seen the push towards like comprehensive stroke centers, is because they have not just TNCase. TNCase is a medication that any hospital can stock, and I was about to say, D3's got TNCase. But the difference is that there aren't other options, in that like there aren't the neurosurgeons, there aren't the neurologists there per se, there definitely aren't the options to do clot retrieval, where they actually physically go and remove the clot instead of trying to break it up. It's just a messy medication sometimes. Any other questions? That was a good one. I know, one day I need to bring like a happy case. These all end so, ugh. Maybe I should add.
Well, that was kind of a happy ending.
Is it?
They're alive?
She is? Okay, she's alive. She alive? She went to rehab? Yeah.
Symptoms are getting better.
With a worse injury that she went into the hospital with, but yeah. It only took them 7 days, not 7, 3 days to place her in an inpatient rehab. That's all I got, y'all. Any other questions about anything? That's so you're gonna give people another opportunity to think of a question to ask. I mean, it's your choice, but